a tough day today.
Sounds like it.
Yeah, I don't have late days. I'm a good planner, so I don't like being late.
That happens to everybody sometimes.
Sometimes it happens many times in the same day.
Yep.
How are you?
Only everything we're in our control, right?
Oh, today nothing felt like it was in my control. I don't know. Be able to see. Okay.
That's for you, Dr. B.
All right,
They're
Dr.
clapping
B.
for you. Hold on just a second.
Oh, big time. Does that mean I'm a go?
Okay, you're a go.
Okay.
Okay.
Mute your.
Yeah, mute your.
All right, I think we're good.
I think we're good now.
Nope, you got to mute. All right, now we're good. All right, so what we need to work on is getting a camera so I can see you guys, so I can have some kind of feedback. It's very much a one-way thing. So I apologize for running late. One of those days in the OR where you take a week of vacation and you come back and you have a day of revision surgery, and then a friend of yours says, "Hey, look, why don't we talk about subchondroplasty?" So I apologize. I'm here. My name is Chris Baker. I'm from the Florida Orthopedic Institute in Tampa, Florida. I'm also associate professor at USF. Let me get this thing rolling. This is how I looked pre-COVID. I used to be clean shaven, and now I don't give a damn, so I don't shave or anything like that. I did all my training in Pittsburgh. I did UPMC general orthopedic residency. I then went on to do a fellowship in sports medicine and shoulder reconstruction at Steadman Hawkins Clinic of the Carolinas. We're going to try to cover a lot today. So Michelle, I know she'll interrupt me and kick me forward as we need to, but I've been asked to kind of share with you guys my insight and knowledge on the subchondroplasty procedure. Most relevant probably to the knee. Near and dear to me is in the shoulder, also performed in the foot and ankle and hip. We can touch briefly on the osteoarticular allograft kit, or the OCA kit, or what formerly was known as De Novo, and then BioQ, which is pretty straightforward. It's a BMAC product that Zimmer Biomet offers. Jumping kind of into my experience and how I got into the subchondroplasty procedure, I'm a shoulder and sports guy. I do sports knee, but I do everything in the shoulder from arthroplasty to cuff repairs and fractures. But I don't do total knee replacements. And I had a lot of patients that were having kind of pain in the knee that weren't quite ready for a knee replacement. I didn't want to send them to my joint guys that were going to basically kind of send them back to me. And honestly, I just didn't think they were ready for it yet. And I kind of came across a pamphlet back in 2013 with a picture that was very similar to this. And this was my very first subchondroplasty patient that I ever performed. I identified her as having spontaneous osteonecrosis. That was kind of my diagnosis for this patient, which I'll show you. If we have time, I'll show you her case later. But as time has gone on over the past several years, this diagnosis has really gone on to be diagnosed as a subchondral insufficiency fracture. And there's some pretty good pathologic studies on that. So in the past 8 years now, I've done probably approaching 350, 400 cases. It sounds like a lot, but if you kind of break it down, it's not all that many. I definitely did a lot more when I first started. We were kind of trying to figure out who was a good patient, who wasn't. So my indications were a little more open. I've kind of narrowed them down and kind of found a little better protocol for me. People commonly ask, who's the ideal patient? That's a very hard question because I've done this on people in, 80 pounds to 360 pounds BMI. over 50, age range from 26 to 87. So it's really kind of all over the place. And I think by showing you some indications and examples, you can kind of find your own practice where this works. Current indications for me, still the most common is this the bone marrow lesion associated with arthritis. In this patient, he has a femoral antibial lesion with no meniscus, but had relatively well preserved joint space on exam. What used to be called spontaneous osteonecrosis, which is really now just a subchondral insufficiency fracture, as we've kind of learned about these. OCD lesion, or excuse me, metaphyseal stress fractures. These are not diaphyseal. They're not typically going to be supportive of the bone, but they're very painful and can sometimes be very difficult to treat. OCD lesions that are in somewhat difficult to reach places. I've backfilled these and had really good results, and maybe we'll get to that and show you some cases. AVN in the hip is a really good indication. AVN in the foot and ankle. AVN in the shoulder has worked well for me. I haven't had great experience with AVN in the knee, but I've only had like one or two, and they've just been really, really bad cases. So I think it just wasn't necessarily something that could be salvaged. And then for me, the shoulder has kind of been near and dear to me. The humerus and the glenoid, I've done a lot of research on this, and we've developed some techniques on this. And then I had one cool gee whiz case in a hip fracture that I did a percutaneous fixation for. When we look at bone marrow lesions, it's a generic term really describing an increased signal on MRI evaluations in a T2 weighted image. And the way that this came about was in the late 80s when we were kind of really feeling out MRI still. We were looking at these T2 weighted images, and you could see these pockets of fluid as a high intensity signal on T2 weighted image. But the bone also kind of had a higher, brighter appearance. So what we started to describe these as bone marrow edema. And simply because we were looking at fluid on one part of the MRI, we kind of assumed that this would be edematous as well. And we'll go into the pathology of this, that there's really not any real edema or fluid or anything like that in these bone marrow lesions. But more importantly for me, as I've learned about these things, is that I used to think of the bone marrow lesion as a sign. And now I really think of it as a symptom. So when I see that bone marrow lesion, I think, okay, this patient's going to have more pain than the average bear. We got a different set of problems that we need to handle. And I think that becomes from our history of how we used to, like, let's say an ACL injury comes into your office and you see that lateral bone marrow bruise on the lateral femoral condyle, lateral tibial plateau. You don't really think of that as being painful, but you think of that as being a sign of a prior injury, including an ACL. So they have a pivot shift injury, they get a bone marrow lesion of the lateral femoral condyle, the lateral tibial plateau. Aha, they have an ACL injury. Well, when I look at this, I think about the pain that can be generated from that lesion. When we look at the bone marrow lesions, we have very good data that shows that the bone marrow lesion is the main source of symptoms in knee pain. It also basically represents a microtrabecular fracture, and when it goes untreated, it can really predict progression of the disease. So we look at the bone marrow lesion as a main source of symptoms. Let's go back to just basic anatomy and physiology. When we look at the actual anatomic structures in the knee that can hurt you, what actually can cause pain? Articular cartilage has no pain fibers. It is avascular, it is aneural. Part of this talk is going to talk about cartilage restoration, and that's probably about what the past 20 years, 30 years of orthopedics is really focused on in the sports world is articular cartilage restoration, and it's an avascular aneural tissue. So if I can tell my patients I can get rid of their pain and they are still going to have some kind of cartilage defect, they don't care as long as their pain is better, and that's how I feel about it as well. Synovium does have pain fibers, but it's mostly involved with baroreception. So if you have a large effusion of the knee, then that patient's going to have some pain related to that distension of the joint. But it's really not much when it comes to a non-distended knee. The meniscus obviously has pain fibers. If you look at the model down below, the little cartoon here, the pain fibers, though, mirror the vascular supply, which makes sense. So that red zone, when you have a nice deep tear that goes into the meniscocapsular junction, that one's likely to be painful. But when we're dealing with these tears that are in the white zone, or even tears that have become dysvascularized that are within the more red zones, those are less likely to have pain fibers. Ligaments do have pain fibers. Maybe on that first initial injury, the patient might have some pain. But when it comes to chronic instability, pain really should not be their issue. Oops, my Siri is jumping on. But when we look at bone has a very high density of pain fibers. We're all very familiar with the pain fibers associated with the periosteum as generating pain with regards to fractures and periosteal elevation related to infections. but the subchondral bone has a very high density of pain fibers as well. When we look at some basic science, even going back into the 90s, looking at articles like osteoarthritis and cartilage and radiology and other types of articles, there's really good evidence to show that there's little correlation between joint space narrowing on an x ray film and the patient having knee pain. And I see this all the time in my office because we get bilateral weight bearing films on all of our patients where they'll come in and I predict that, the knee on the left, which has no joint space, is hurting the patient, and then no, actually it's my right knee. It has good space, but it hurts. And the reason for that is hard to understand until we get MRIs. So when you look at an MRI, which is the next study by Hunter, what they found is they basically looked at MRIs in patients with knee pain and tried to associate predictors of having knee pain or correlation of knee pain. And what they found, also similar to what was on X-ray, was that cartilage volume and thickness was a weak predictor of having knee pain. So if they had very thin cartilage, very narrow joint lines, that did not predict knee pain. There was a moderate association with synovitis and effusion. So if they had a big fat swollen knee, they had pain. But if they had a bone marrow lesion, that was the strongest predictor of having a knee pain in their study. When we continue to look at this, Felsen has done a lot of the research on this. He's also the gentleman that did the studies that were published in the New England Journal of Medicine in the early 2000s that really kind of debunk the idea of degenerative knee scopes. So we're going in, cleaning up cartilage and removing loose bodies, yet the patient still has pain, still has progression of their disease. And that's where he kind of picked up on this idea of the bone marrow lesion and the pain associated with it. And he's basically concluded that the bone marrow lesion is the strongest predictor of the presence of pain in a patient with knee arthritis. You can go back through tons of journals. I really tried to narrow this talk down a little bit because it's pretty expansive. But back in the 80s, they were talking about insufficiency fractures causing knee pain. 2001, Annals of Internal Medicine, 3/4 of patients with bone marrow lesions have knee pain. And this one in radiology in 2011, they identified way back then that patients with arthroscopic partial meniscectomies with coexistent bone marrow lesions were less likely to do well postoperatively. So there's lots of good data to show that the bone marrow lesion really is the primary generator of knee pain in patients with early OA. They also represent microtrabecular fractures. So when you look at this patient up here on the top right, a lot of folks would kind of consider this to either be a bone marrow lesion, maybe an old school spontaneous osteonecrosis. But when we look at this, what I picture is this exact picture. I picture this histological image of this kind of increased signal, which is due to increased cellularity in that area. You can see the cells in this area, and then this subchondral fracture. So that's kind of what I picture when I see a bone marrow lesion. When you look at the pathology of the bone marrow lesion, what you really see is essentially a healing fracture. You have these Howship's lacunae, you have all these osteoclasts, all these osteoblasts that are trying to break down and build up bone. But what you see is this hypercellular environment, this abnormal hypercellular environment, which is more like a non-union. And that's really what these look like if you take micro CT scans and histological sections of these. You see these large fissures that are within regular trabecular bone, and these become hypercellular. You can even see them on a high sensitive CT scan where you see these holes in the bone. You might even see them on your tibial cuts when you're doing total knee arthroplasties. So when you look at this, Zanetti published this in 2000 and Bergman in 94. They really found minimal true edema in these bone marrow lesions, and they really found all these areas of excessive remodeling really kind of mirroring that of a fatigue fracture or a non-union fracture. This was a study that kind of really talked about these spontaneous osteonecrosis diagnosis. What they looked at was patients that had a prior arthroscopy that then went on to do poorly, requiring arthroplasty. And so they had all been diagnosed with spontaneous osteonecrosis, but they took their sections of the knee and sent them to pathology. And what they found were these subchondral insufficiency fractures. So this is kind of where we started to turn away from the idea of SPONC for these and more into that subchondral fracture diagnosis. The bone marrow lesion also represents progression of disease. And when we look at the progression of disease, this is what I like to kind of talk to patients about. When you look at bone, it's the perfect organ, right? You injure it, you fracture it, you put the ends together, and it remodels, it heals. And it does so without scar. So that's a pretty unique organ in that it can heal on its own. But in these patients, for some reason, at some point, their capacity for remodeling is exceeded. And that's where we start to get this hypercellular response, and we start to get this hyper recruitment of abnormal cells, and the bone marrow lesion develops. And if that continues, the bone continues to break down until you get subchondral collapse, and basically attrition of that bone and then collapse of the arthritis. When you look at different articles that have discussed this, Romer, who is in the most study evaluating osteoarthritis and a large multi-center study, basically what they found was that patients who had bone marrow lesions basically would have a progression of disease. They could predict that that patient's osteoarthritis would progress at a more rapid rate. They also found the converse to be true, that patients with osteoarthritis without bone marrow lesions were less likely to progress. It sounds intuitive, but it's not always easy to kind of show both of those in the same study population. These are the actual things that I like to discuss with my patients. When they come into me and they have a meniscus tear, usually they have an MRI that says, okay, I have a meniscus tear. And I say, ooh, but you got this bone marrow lesion and I'm worried about it. The reason I say that is that all of our patients have had that friend who had a meniscus, they had a knee scope and they walked out and they were like perfectly better right away. I explained to them that they're different and this is why. Because you have this bone marrow lesion, you are 9 times more likely to need a knee replacement in the next 4 years. And this is out of Skeletal Radiology in 2008. This other article, Rheumatology 2010, having that bone marrow lesion in addition to your meniscus tear makes you 57% more likely to need a knee replacement. The presence of a medial bone marrow lesion, one of the strongest predictors of needing a total knee. Large medial lesions or worsening lesions, 2.5 and 3.4 times more likely to need a knee replacement. So it puts the foundation in the patient's head that, oh, I don't just have a meniscus tear, I now have a fracture in my bone. And if I don't act right and kind of be careful with this thing, it's going to progress and I may end up needing a knee replacement. But is it really a fracture? And this is kind of the hard part, I think, in the knee that folks have a kind of hard time swallowing and treating and kind of moving on from. So I found this article when I was studying for my boards back in 2013. This is actually out of our AOSSM and our review like packets if you want to review old questions. This is a 32-year-old runner, recently increased her distance while working for a marathon, medial knee pain with running, no swelling, no locking. Examination shows isolated pain over the medial joint line, no effusion, and a negative flexion McMurray test. They've already given us that the radiographs are normal, and the MRI scan is what we're going to be evaluating, and they're looking for a diagnosis. So as we look at this MRI, we can see a medial tibial lesion here. On the sagittal views, you can see that same medial tibial lesion, and on the coronal views, same medial tibial lesion. So let's look at the rest of the knee. The MCL looks perfect, no strain or sprain to the MCL. Medial meniscus looks great on both views here.